Yeah, hi. On behalf of the American Academy of Orofacial Pain, this is Jeff Schaefer. I'm the acting president of the AAOP. I want to thank today's organizers for the webinar and all of our attendees this morning who are in the U.S. and also this evening for those across the Atlantic. The idea for this webinar stemmed from last month's webinar on the effects of pandemic on our orofacial pain patients. It's evident that to best help our patients, we need to understand them completely, and understand the effects of social determinants of health on our patients will help us achieve that. For instance, we know that people that have good family support are going to respond to chronic pain treatments, and that family support is critical. I'm really looking forward to hearing our expert panel today. I think it's going to be very interesting, and I hope you enjoy it.
Well, my name's Jeff Crandall, and I'm contacting everybody from Vermont, as you can see in the background. The initial discussion will be with regard to the social determinants of health. And I want to introduce the panelists for you so that you understand who is speaking. More details regarding their particular status and credentials is available through Dr. Caspo. So let me introduce, in no particular order, Dr. Flavia Capos, Danielle Manfredini, Ian Boguero, Ron Kulich, Jim Frickton, and Steve Bender. And I'm sure all those names are familiar to you. We frequently talk about the biopsychosocial aspects of orofacial pain, but do we seriously consider the social aspects of our patients' lives? In light of the COVID-19 crisis this past year and the recent weather disaster in Texas, the elements of housing, food, transportation, utilities, employment, finances, and personal safety have become increasingly important social factors in chronic pain management. Isolation these days has become an SDOH concern as well. And an article in Discover magazine this month describes how shaming and cyberbullying on social media has become a major influence on the lives of the victims of this behavior. So the first thing I'd like to do is introduce Dr. Steve Bender, who will offer an overview of the Texas winter weather disaster in the context of COVID-19 and its recent impact on the SDOH in that area. What happened in Texas last month is something that speaks directly to SDOH. If we think about it for a moment, rightly or wrongly, the Lone Star State decided long ago not to connect with the eastern or western electricity grids, choosing instead to go it alone. This social distancing, I guess you could call it, of their electrical power has resulted in the collapse of their system due to the bad weather, and in turn resulted in a massive weather crisis water crisis as well. Texans were not only freezing to death in some instances, but were without potable water. This is a superimposed on the COVID crisis. So let's hear what Steve has to say. Go ahead.
Well, thank you, Gabby, and thank you, Jeff, and everybody else that's been a part of putting this on, and for allowing me the opportunity to take you on somewhat of a brief tour of what happened during this most recent crisis. And again, you compound it onto the COVID crisis, and I think it gives us a really good example of the social determinants that may be involved in our patient's presentation. So give me just a minute to share my screen. Okay. So on February 11th of 2021, this is what we awoke to early in the morning. We had been given advance notice of a freeze coming through our area, and many schools, many businesses had already closed. But with essential workers, you can't really shut down that much. So there was a lot of people on the roads. And the problem in the South is when we get ice such as this, it develops what we call black ice. In other words, a thin sheet of ice that is not really very visible, but can be quite dramatic in its end results. So this was a huge pileup in Fort Worth, which is just west of Dallas. There were approximately 133 vehicles involved in this pileup, with 6 dead and many, many more injured. We knew that more was coming. In fact, they warned us that it was going to get worse. We were going to be involved in a serious snow and ice storm. And on Monday, the 15th of February, many of us awoke to power outages. So indoor temperatures for a lot of folks were in the 30s and 40s without heat, without power. And what we found out later is that our system was 4 minutes and 37 seconds away from total collapse, which would have meant weeks to months of downtime. And that would include gas stations, grocery stores, everything would have been without power. So people obviously, they told us we'd be having rolling blackouts of about 45 minutes. Well, it didn't take long for us to realize that 45 minutes meant all day. So many of us were without power for up to 3 days at a time. So people were doing whatever they could. Fortunately, gas supply, natural gas, was still available for some people. There were warming centers made available. Many people that thought they would never need such help were forced to go to centers to try to stay warm. Even the military, different military branches were involved in getting people to these warming centers because it was just too dangerous to drive. Some of the local furniture stores would open up and allow people to come in to warm up. There were certain pockets of areas where power was maintained, and these were around hospitals, nursing homes, first responder centers. And so some of these department stores had power available. And again, many people that never thought they would need such assistance were forced to seek help for shelter, for warmth, for food. Fortunately, Texas has a very giving spirit, as many places in the country do. And so volunteers jumped into action to get those most needy into places where they could be helped. People found ways to deliver food to people without food. People looked for any way that possible that they could stay warm. And so they would build fires on the outside of their house to try to stay warm. As you can see, families in their homes were bundled up. I personally had at least 3 layers of sweatpants on, double layered socks, maybe 3 or 4 layers of coats and gloves. And then there was the freezing pipes. So water would start to burst, water pipes would burst and then ultimately freeze. This poor individual had parked right under a water pipe. It burst and ensconced her car in complete ice. And then you can see the damage that was caused by these burst pipes. Many people, their ceilings were collapsing, their houses were flooding, and so unfortunately they were forced to leave for that reason. Because of the lack of water, people were gathering snow from the outside. And again, a lot of people had gas available, so they would boil the snow to use to melt it for water and to use like in their toilets and other things. Grocery stores, many were affected. This is a gentleman checking the temperature on foods to see if it needed to be discarded or not. People were allowed in to get what they could. In some cases, the stores had no power, so they couldn't take money. So they were just going on the honor system, letting people pay what they thought it was worth at that time. And a lot of stores were forced to either clean out their shelves or they were cleaned out by customers. And of course, new trucks could not come in to supply. So the stores that were open were running out of food. And you can see many stores were just closed because they didn't have electricity. The stores that were open had very long lines of people. These lines would go blocks and blocks of people waiting to get in just to get some bare essentials. And as was mentioned, water was not drinkable, and so people were finding whatever method they could to get water to take home to use. Again, a lot of corporations and entities were trying to provide water, drinking water for people. And then probably the most disturbing aspect of this was the loss of life. This was a young man that had never seen snow before in his life. He was out playing in the snow one day, and then the next day he passed from hypothermia. Another case, a family was without power, a grandmother and her grandchildren. And so they were probably using a fireplace or some other mechanism to try to stay warm, and the house caught on fire. So again, some beautiful lives were lost. And there were a lot more people that were lost during this time due to hypothermia and other means. So with that brief tour, you can see, if we look at the social needs screening tool, and this is probably kind of small to see, but we look at housing, we look at food, transportation, utilities, childcare, all these things were impacted in just a very brief period of time. These are things that we should be asking our patients about, because the fear of losing housing, the fear of being without food or water can have a significant impact. So hopefully that kind of whets your appetite, if you will, to what looks like is going to be a great presentation. So thank you for allowing me to share, and I'll be sticking around for questions.
Okay, thank you so much, Steve. The next discussion is going to be with Dr. Kapos and Dr. Manfredini. And this discussion is with regard to what constitutes the SDOH in our patients' lives. This is an overview of SDOH and makes reference to many of the elements of SDOH as indicated on the American Academy of Family Physicians Social Needs Screening Tool that Dr. Bender just presented. So I will now turn this over to Dr. Kapos and Dr. Manfredini.
Thank you, Steve, and thank you all for the space to be talking about this today. I'm really excited that we're having this conversation and we're taking advantage of the momentum that there is around this whole topic to bring it closer to home and see what's our role in all of it, you know, as individuals and as members of the orofacial pain community. So a brief preface here that, you know, the topic is really vast, so I'll try to give you an overview, and we're probably going to be raising more questions than answers. But if we are able to get people interested and looking for more resources and starting these conversations, I think this will be already a big start, because we're all familiar with this idea that we need a good diagnosis and understanding of the problem before we can act. So we maybe as a healthcare community and as a society as a whole, we're still kind of wrapping our heads around it and how we can diagnose the problem and start by building this shared understanding. So what are the social determinants of health? The World Health Organization defines the social determinants of health as the set of social forces and systems that shape access to power, money, resources, which in turn influence the circumstances of daily life across the lifespan. So those are things that are well beyond the traditional medical care that we immediately think about when we talk about determinants of health, and they touch on sectors of society that that we don't necessarily feel responsible for, but they really do influence the lives of people and their ability and their opportunities. And as we're going to go more in depth here, they really shape the biological and the psychological aspects that we consider as the social determinants of pain. So I'm a huge fan of Dr. Kamara Jones. She is in the field of social determinants of health, and she has some really great analogies that I'm going to try to leverage here to go along with the idea that a picture is worth 1,000 words. So this one is about the cliff analogy, and the interesting thing about it is that it helps us understand different potential levels for intervention. So the cliff represents challenges to health, and people are on top of the cliff. And there are different levels at which we can either treat or prevent these health problems. So the traditional thinking generally is around the ambulance that is sitting at the bottom of the cliff, but we shouldn't have to wait, for people to fall off. So there's kind of a safety net ahead of it. So that would be maybe like a secondary prevention. And then at the top of the hill or of the cliff, there's this fence that would be more direct preventive strategies. So thinking in the context of pain, it would be maybe behavioral interventions or trying to have people stay healthy. And addressing the social determinants of health would be to move the whole population at the top of the cliff further away. So getting people the resources that they need to stay healthy. But then if we look at it from a three-dimensional perspective, we notice that the cliff, that people on top of the cliff aren't really equally distributed along the edge. So in parts of it, there are more of these protective barriers and curative resources than others. So addressing the equity determinants is realizing that not everyone has the same access to preventive and treatment resources. And so addressing those would mean to not only do sort of universally applied social determinants of health interventions, but targeting these communities and populations that are in greater need. And so there's a very wide range of social determinants of health. We've mentioned a few of those, and we saw them in how they are really speaking very loudly during this COVID pandemic. They're really emphasized by the multiple overlaying crises that are happening. And where are those things when we talk about orofacial pain, and our mental models of etiology of orofacial pain. So as many of you may be familiar, this is the opera model, which is a really, important series of studies that happened in the past decade in our field. And really, we have to put a little magnifying glass to find the social determinants. They're kind of sidelined. Of course, you can't really go in depth into everything, but they are here presented as sort of modifiers or moderators of the other things. They're not presented as causes. And the detail in terms of what are the pathways through which they would influence health aren't really outlined. So that really doesn't stimulate our thinking about how to intervene. And why is that? And Dr. Crandall rightly mentioned in the beginning, we are used to talking about the biopsychosocial model, but it's not really well balanced throughout. After it was presented in the 70s, late 70s and 80s in the field of medicine in general, it was really embraced by the pain field, but it has had over the past couple decades a big emphasis on the psychological side. And I think this is a huge advance that has really improved care. But I thought it was interesting that there was this article from Turk and colleagues from 2008 that it said psychological approaches in the treatment of chronic pain because pills, call pills, needles are not enough. So I would say that addressing biological and psychological is not enough. So the next frontier, and hopefully this is a good moment to really get on these topics. I think that this is maybe a little controversial here, but I think we do ourselves a disservice when we say psychosocial as a synonym for psychological and social, because we are kind of conflating the two, and the social ends up being really sidelined. So maybe we can start an exercise to talk about really purely social things and how they influence pain and health in general. And here's a quick plug to an article that I've been working on with some colleagues from the International Association for the Study of Pain, Social Aspects of Pain Interest, Special Interest Group, that we're developing a multi-level, intersectional, and life course model for the social determinants and social consequences of pain. So our goal is to present a model that will help people to think in these ways more in depth about the social aspects of pain and potential ways that we can intervene and go from there. So how important is this issue? I'm not gonna state too much on the evidence here, but we know that the magnitude of social determinants is really, really large. Although the effort has been focused a lot on the biological and the psychological, I think we're really missing out here on some big and influential factors. So also from the OPERA cohort, they had more than 200 risk factors that they evaluated in their models. And the third strongest one turned out to be the study site, which is usually, just adjusted as for good measure, but it turned out to be really predictive. And they speculated that it represented some unmeasured social and contextual factors. And in the US, this recent national survey found that the prevalence of high impact chronic pain, defined as pain on more than half of the days for at least 6 months, with an impact on daily activities, was 4.5 times greater in adults below the poverty level relatively to those in that higher family income. And that effect size is just huge. We don't see that a lot in epidemiology and other research approaches. Again, you may have heard about the zip code telling you more about somebody's health than their genetic code. And in pain, we've had some recent confirmation of that, that the stress that participants in this study completely overwhelmed the differences by genetic haplotype of the COMT enzyme, which is associated with stress and pain sensitivity. So, and then lastly, thinking more at the group level, there's also really good evidence that neighborhood disadvantage and social capital, so thinking beyond the individual, things that increase risk of development and progression of pain, and also some other comorbid conditions. And what are these pathways through which social determinants impact health? There's this hallmark study by Link and Fallon from '95 and they present the theory of fundamental causes. I highly recommend that article, and at the end of my slides, I have a few, must-sees, and that one is one of them. But basically, the overall mechanisms are shared between lots of different health outcomes, and these social forces, they shape the distribution of flexible resources like money, knowledge, power, prestige, opportunities, and social connections, which help people to stay healthy and also manage illness when it occurs. And one of the key take homes from this type of approach is that these resources are flexible, and so they change over time. And I thought about that when cyberbullying was mentioned earlier today, because this is something that didn't used to happen, but it's one way that the systems of power and privilege and they adapt to cause and affect health in new ways. So addressing these proximal things, so the mediating mechanisms that are closer to people, closer to individual level, may not address these health disparities. So we really need to think about going upstream. So in public health, we often evoke this image of the river, and the river being, some health problem and people drowning. And we as clinicians are often, jumping into the river to pull people out of their problems and try to help them, because we see they are drowning, but we don't stop to think about who is upstream throwing people in the water. And then we do studies about like, some people seem to swim much better than others. Let's try to teach people how to swim, and that helps too. But I'm proposing here that we should also devote some time and energy to think about what's really upstream, and that would be the social determinants of health. And so thinking about pathways, a lot of these are shared between lots of different health outcomes, so we can benefit from research that has been done in other fields. And we see that these social determinants, they shape the daily life conditions, and they also shape psychological determinants like coping skills and other aspects of personality and ways through which people deal with stress. And that ultimately gets embodied into our system, for example, through neuroendocrine systems and creating a pro-inflammatory state, and that also shapes health behaviors, and of course access to medical care, leading to multiple outcomes like pain. Specifically for pain, there are these domains of threat and deprivation and toxic stress that have been presented as sort of core mechanisms through which social determinants influence mental illness development. And this is very critical thinking about early life. And so these general avenues through which social determinants can influence pain are by increasing risk of exposure to pain, increasing vulnerability to pain, and reduce resources to prevent and treat pain. And so in conclusion here, I'm also a huge fan of Dr. Nancy Krieger's work. And there, in one of her most recent papers, I thought it was very interesting that she says, well, she has been saying that forever, but I thought that this one was very on point, that we don't do research about social determinants of health to document or to prove injustice. We should do it with a lens to try to challenge these narratives that, for example, present these individual biological and psychological factors as inherent to people, and putting kind of the onus of not being resilient enough or doing self-destructive behaviors, for example. So without checking what's happening further upstream and thinking about how we can act on it. And so all of those social determinants are human-made. So we also tend to present them as fixed or non-modifiable, and for this reason we kind of stay away from them. But we have ways to address them, both as kind of a band-aid, you know, like we can and should do things when people are already struggling. But as people with a lot of privilege, we should check our role as when not addressing these things, both in practice but also in our lives, and using our political and economic power to support these equity measures. By ignoring them, we're letting them perpetuate and get worse. So now that we know that they're there and how we can, that we do have a role in it, we can't ignore it, and we should get together to really think about a clear vision and strategy of how we want to address it. And here are some recommended resources. I highly recommend this YouTube video with a few more allegories that explain structural determinants of equity and health. And a book there by Sandro Galea, and a couple of classic articles by the original author of the biopsychosocial model and the fundamental social causes. And then this last one is about bias and discrimination by socioeconomic status and race in pain care specifically, and an intervention that was successful in reducing that. So it is widespread. And if you guys have seen the latest JAMA podcast and Twitter scandal, if not, look it up. But we have to acknowledge that, you know, these injustices are happening very nearby, and sometimes we are part of it, and so we need to talk about it. That's it. Sorry, I went a little over time here, but I will pass it off to Dr. Manfredini.
Thanks, Flavia. Don't worry, it's been wonderful to listen to your presentation, because I think that it's been the ideal beginning and overview presentation of what's going on over the next hour or so. I'm talking from my Tuscany in Italy, so it's almost appetizer time here, and I see that many friends from Europe are connected, and also some from Italy, my friends of the Italian study group on orofacial pain. So welcome everybody, and special thanks to Jeffrey, Gabby and Jeffrey for this invitation. So I'm really proud of being here, and I think that my very brief spot here is almost perfectly linked with what we have listened from Flavia, because as a clinician with the passion for research, I've always felt that, as Flavia pointed out, we focused a lot on the biological aspects of pain in the past, and then on the psychological, and we maybe not so much focus on the social aspects of the model of pain, but I always feel that the reason is pretty understandable. The social aspects are not easy to measure. So we can assess the effects, or at least the potential effects, that the social determinants have on the psychological sphere of the patient, but it is not so easy to get to the mountain and not to look at just the valleys or the effects of the social issues. So we know from a psychological viewpoint that the standard of reference are the DC TMD, and from Axis 2 findings, we reviewed the literature some years ago, and we know that many of our patients have potentially even severe somatization level or depression level, but luckily for us, the amount of individuals with high pain-related impairment is not so important as we could expect based on the levels or intensity and frequency of somatization and depression score. So this is a good news. The challenge for the future, in my mind, is to understand what's the link between those findings, which are clearly important in the everyday life, and the Axis 1 findings. Because as clinician, we cannot forget that many of these patients go to the dental offices. I'm a dentist. So in a dental office, many of the time is spent, forget occlusion, but at least thinking about how to manipulate joints, how to palpate muscles and that kind of stuff, which is not necessarily what our patients need to be properly assessed and managed in the clinical setting. So the real issue is that there is not a perfect, or not at all a connection or a correlation between Axis 1 and Axis 2 findings. It means that my muscle or joint diagnosis is not so correlated with the somatization and depression level I can, or pain-related impairment level I can measure with the Axis 2 of the DC TMD. And from our data gathered on over 1,000 individuals in 2011, it seems that the real difference is to be a treatment-seeking individual. So what makes the difference between individuals with a clicking joint, walking on the seaside of my Marina di Carrara today, and the very same joints of individuals asking for advice in our offices? Maybe there is something at the social level that we are not able to measure from a psychological viewpoint. And that could be an interesting argument for future studies in this study group that we are gathering together. And importantly, the psychological determinants of treatment are overwhelmingly surpassing the Axis 1 findings as for treatment outcome prediction. Some years ago, we even showed that the arthrocentesis is much more predicted in its effectiveness from the psychological than from the physical findings. And that's at least funny, not to say unexpected. So, as if we were predicting this webinar, some months ago, together with Chuck Green, we went to work to prepare a paper on the vulnerability of patients transitioning to chronic TMD pain. Who's the patient at risk for pain chronicization? And of course, we may have anatomical findings, but the psychosocial factors are really important. And there are many factors belonging to the psychosocial sphere that are not strictly measured and evaluated in the axis 2. If we go beyond the axis 2, we can easily understand that some individuals may have an illness behavior, whether in the form of negationism or in the form of the other extreme, the seek role, that may predispose them to transition towards chronic pain. Some of them may have secondary gain. And the question is, how to measure secondary gain? It is not possible. So it is just something we have to be prepared to understand with some, let me say, psychological technique to embrace the patient and to create empathy with them. Then there is the factitious disorder, the so-called Munchausen syndrome, even by proxy. How many parents are surprised by our statements that their sons or their daughters' clicking joint is not actually a problem that requires surgery or whatsoever? How many parents are really willing to engage in psychological and social talks about the causes of the headaches of their daughters? That could be another problem because some patients seems not willing to accept non-mechanical approaches, at least in the field of temporomandibular disorder, which is one of my major fields of activity in the clinical practice. So sometimes the patients has factors that are not easily understandable even by questionnaires or that kind of approaches. Of course, there is genetic predisposition, also by the predisposition to show some intermediate phenotypes. How are you reacting to stress? So stress sensitivity may be genetically predisposed, so indirectly predisposing to pain, for instance. And then there is the complex issue of iatrogenesis. Of course, iatrogenesis is not necessarily related with the social issues, but what about individuals undergoing extensive treatments, undergoing an abuse of oral appliances? Our personal record, together with my friend Luca Guarda, is to have an individual with 22 oral appliances. How about the psychological and social determinants in those patients? Not to say the nocebo effect, iatrogenic hypochondria, telling some patients, oh, you are not able to open your mouth and you risk to not being able to open your mouth in the future as well. Something like creating patients, over-medicalizing them. So that could be another factor that may have social impacts, because we never know how the family environment of the individuals will react to this kind of experiences. Never forget that pain is an experience. So my 2 cents for today, just to move forward with the discussion, I don't want to bother you too much, is how to evaluate these factors. To me, that's really what we are missing. I remember in one of our previous email exchanges, Jeff Crandall suggested that this could be a sort of axis tree of the DC-TMD or whatsoever. And I think that it could be something to chew on in the future. So That's my provocation for today. Also think about iatrogenes and the patient history as a possible factor having social influence. If you have any questions, of course, we are here.
Thank you, Dr. Manfredini. Next on our list will be a discussion regarding how do we approach our patients and ask questions regarding their sensitive personal affairs that influence their SDOH. Doctors Kulich and Boguero will offer a sensitive means of introducing the SDOH into our interview and dialogue about the role that these factors play in our orofacial pain patients' lives. Gentlemen?
Thank you very much. I'm going to go ahead and share my screen here. So give me just 1 second. Well, I'm Dr. Ian Boguero, and I'm a clinical psychologist by training. And I want to thank all the other panelists for the very great information that they've presented so far. And I think what I've heard from all the panelists is a very strong justification for what the social determinants of health are and why they're very, very relevant to orofacial pain care. And you might be thinking as an attendee here, well, I understand that it's important to assess these things, but how do I do that? And as a dentist, how do I talk to patients about this area of life and these domains of life that historically have been very much outside the realm of dentistry? So I want to spend about just 10 minutes here giving some pointers on how you might go about assessing social determinants of health if you so choose to do this in your clinic or in your practice. And I want to start this conversation off by saying that asking sensitive questions can be really uncomfortable. And it can be uncomfortable for a number of different reasons. First, if you're like most dentists, you probably don't have any specific training in how do you talk to patients about very sensitive topics that are historically been outside of the field of dentistry. So, and there's always fears when doing this. Some of the fears might be that patients just might not want to talk about these things and that they might be offended for even asking about this. Another fear might be that we'll get a very strong negative reaction or elicit some very powerful negative emotions if we touch on a domain of life that's very stressful for the patients. And then another fear might be that if patients are experiencing some social determinants of health, how do we even go about beginning to make a change in that? So there's all kinds of fears that as a provider you might have for asking these really sensitive questions to patients. And I want to start this conversation off by saying that asking sensitive questions can be really, really uncomfortable. And that's the first part of the sentence. And the second part is, but that discomfort shouldn't necessarily keep you from doing so. And the reason is that even though it may be uncomfortable potentially for the provider and the patient to some extent, knowing this information is of really critical importance. And when the patient comes to see you, if they are experiencing any of these obstacles, as a dentist, you can direct them to valuable resources that might have a big impact for the patient. So the discomfort is outweighed by the importance of knowing this information. So then the question becomes, okay, how do I do this? How can I even assess this in practice? And I'm going to argue that the best way to actually assess these things and how you ask the questions is really dependent on the context. because each context and each setting, each clinical practice has a whole set of barriers, which you'll hear about a little later, that make asking these, all those barriers make the right way to ask this very context dependent. And one of the questions, if you're thinking about implementing these questions in your practice that you might have to ask is, how much time do you realistically have with the patient? There's good strategies for asking questions for if you have a lot of time, and there's also strategies for assessing this if you don't have a lot of time. In psychology, we know that if we ask open-ended questions, then we can get some really rich and valuable information. And when I say an open-ended question, what I mean is a question that doesn't have a definite response choice. So an example of an open-ended question might be, tell me about your situation at home, for example. So when you say, tell me about this, you're not asking for a yes or no question. You're not asking them to rate anything. You're just opening up the question. And then when you ask questions open-ended that way, the patients a lot of times will respond with very rich information and very detailed information. And that can be a really good strategy for asking these questions if you're in a setting where you have the time to devote to listening to the answers and to having a real conversation with patients about the social determinants of health they might be facing. However, it's just not realistic. That's not always the case, that we have the luxury of spending an indefinite amount of time with patients. So if you are in a context with more time constraints, it might be very appropriate to ask yes or no questions. And yes or no questions tend to be quick, and they tend to elicit not as detailed information, but they're much more time effective. And you will still be able to assess whether or not, yes or no, patients are experiencing certain social determinants of health. An even quicker approach to assessing this in patients might be to just give a paper and pencil questionnaire. And we mentioned a little earlier, the American Academy of Family Physicians has a screening tool. So what you see on my slide here is just a screenshot of part of that screening tool, but the full document is available on this link here. And if you're thinking of using the screening tool, I would very highly encourage you to go to this link and look up the instructions and the details for using this instrument. But what this instrument is just a paper and pencil question that has different domains where patients may or may not be struggling. And it just asks them to complete this questionnaire. And what's also really nice about this screening tool is that it comes in with scoring instructions. So this can be a very, very time-effective way to really get a lot of information about different domains that patients may or may not be struggling in. I do want to caution you that if you do decide to implement a screening tool like this or have these conversations with patients, which I really hope that you will, it's very important to keep privacy in mind and just realize that a lot of these social determinants of health are areas that are still very stigmatized. So you want to be sure to ask these questions in a very private setting where other patients or potentially even other staff members may not be hearing the patient's responses. I also think when you have any sensitive conversations with patients, this one included, it's very important to explain to patients why you're asking these questions. You're not asking these questions to judge them in any way. You're not asking these questions to be nosy in any way. you're asking these questions because you really want to know if patients are having difficulty in these domains so that you can direct them to resources that might be helpful. And just explaining how you're going to ask these, why you're asking these questions and what you're going to do with that information is a very important part, in my opinion, of having these sensitive conversations with patients. And the last point that I want to make here is that it's critically important if you do decide to implement a screening like this or have these conversations, that you also have a plan of what you're going to do if the patients do report that they're experiencing some of these difficulties. So, and what I mean by a plan is develop a protocol of different local or national resources for each of the answers that the patients might endorse experiencing. And Dr. Crandall has provided a really nice example of this, an example of a plan he made of a resource list in Vermont. So the information that I'm presenting here is just for Vermont, but this is an example of what a resource list might look like or what part of the plan might be, so that if a patient does, for example, have child care difficulties that emerge, then you can direct them to the resource for assistance with child care. So this is a fundamental aspect of a document you should have readily available if you are going to be screening or if you are going to be having these types of conversations with patients. Directing them to the right resources is really critical. So what I want to do now is I want to turn the floor over to Dr. Coolidge, who's going to be talking a little bit more about the incentives and disincentives for addressing these questions and having these conversations with patients.
Thank you, Ian, so much for that. And I'm going to talk a little bit about some of the barriers, at least from I think what the data may show in this regard. But there was a fascinating question. Previous slide, Ian.
Sorry.
There was a fascinating question in a chat I just looked at, and the question was, what % of patients have these problems? And I'd like to answer it by saying none, if you don't ask any of the questions. And then you could, of course, move on. And unfortunately, that's some of the barriers we face because there is a high prevalence of some of these issues among certainly chronic pain populations. Much of my research over the last few years has been in area of substance use risk assessment, both for pain and patients who don't have pain. And there are significant barriers in terms of addressing some of these. And I love the analogy of falling off the cliff because we really have a number of patients that are saddled with this. I think if you look at the data, things have gotten better in terms of stigma associated with asking and addressing mental health and substance use issues. That's probably gotten better as a result of maybe dealing with some of the opiate epidemic issues. We still have discomfort in terms of asking questions, and there's a perception that some of it may not be relevant. We did some survey work finding even orofacial pain experts feel that some of the content associated with asking about substance use risk still may not be relevant to practice. So this is something a seminar like this is changing. I'm going to focus more on the right side of this this outline, but I will say that even in orofacial pain practices, there's still a certain amount of isolation from multiple other subspecialties, so that limited collaboration. We don't have a social worker we could reach out to, a psychologist maybe off-site. We may not be practicing in some medical settings. So there's a little bit of barrier we have in orofacial pain in terms of isolation. And even though some headway is going on right now in terms of validated screeners, still there are limits in terms of using those. Some of those screeners, I might add, could help you ask the questions. For example, we use the NIDA quick screen, and in addition to just getting 4 items about substance risk, it actually tracks you through what to ask the patient and how to ask the patient, and that in fact can kind of reduce your anxiety or discomfort with asking those. But I want to just spend just a moment or two real quickly on the issue of really systemic barriers. I think that perhaps may be unique to orofacial pain and dentistry. The e-record system is not often talked about as a barrier, but it's a major barrier. If we look at typical medical record keeping systems like Epic, you can pull up sensitive subject matter questionnaires, substance use, depression, and so on and so forth. And it forces you to address these issues right in your screen. In some settings, you're actually required to complete those before completing an assessment of a patient. Typical dental records often don't have that. And in fact, one of the barriers associated with dental records, which are still used in orofacial pain settings, those records don't cross-communicate with other healthcare providers. Lack of access is a major issue, often, I think, in terms of record keeping, that provides another barrier for the field. There's also major financial disincentives. If you're a nurse practitioner, you could ask about psychosocial factors or substance use risk factors. In fact, in some states, you get $25 for asking about substance use. There's a disincentive because that isn't often afforded the dentist. And in fact, I would posit that if you actually pay people to ask some of these questions, or there's the financial incentive, we're going to find dentists, even in orofacial pain, getting a lot more comfortable a lot quicker in terms of asking the questions. We've seen this in terms of sleep disorder. Why do dentists nowadays in orofacial pain and other areas ask so many questions about sleep disorder? Because there's in fact an incentive to do so, although it might be a little over-focused on obstructive sleep apnea. Next, I'll mention a prescription drug monitoring program. In dentistry in general, there's a 40% adherence rate. That's a real problem because the purpose of the PDMP is not to punish the patient or throw it out of your practice, but along the lines of what Ian was talking about, ask sensitive questions. The PDMP allows for a conversation with the patient, and that can be golden, and not just around opiates, but around other psychiatric meds and so on and so forth. Just an informal survey that we haven't finished yet of orofacial pain training programs. There are some orofacial pain training programs where 0% of the faculty are on the PDMP, while there are others where 100% of the faculty are on the PDMP. Again, it's an opportunity sometimes missed. Finally, a couple comments on limited resources. I know in a substance use disorder setting, we could log on to SAMHSA and get a number of resources, some wonderful resources that are outlined by Jeff Crandell in terms of the outline we just saw. And those are great. But again, once you actually drill down, those resources are often not that great in our current society in terms of healthcare, financial access, and so on. If you're rich in Arizona and you have a substance use disorder and a pain problem at the same time, you could go to a very fancy place and have equine therapy where they'll let you comb horses for days on end. Not very evidence-based, but you have access. Whereas those without the healthcare access often might be limited for even evidence-based therapies for substance use disorder. So these are the barriers that are faced. We can't change all of them. I do think there's a future in orofacial pain similar to what we see in some areas of medicine, where we're getting better with consultation liaison services. And this, the COVID and the use of e-consultation can be really a godsend. And we've been doing more talking about how we could set up a consultation liaison service similar to what you see in hospitals, where we do have active psychiatry, social work, and so on and so forth through the virtual system. So anyway, there are a lot of barriers. Ian is optimistic, and I think I am as well, although I think the barriers are still there, but maybe surmountable. Thank you.
Thank you, Dr. Coolidge. Good to hear from you. And Dr. Bagheria, thank you as well. Okay, on to the next section. How do we offer solutions to patients' SDOH that are intended to reduce those factors? Dr. Jim Frickton has prepared some slides with regard to his PACT program that is intended to address management of risk and protective factors that would be of benefit for our patients. Dr. Capo's research will be an invaluable addition to this topic. Go ahead, Dr. Frickton.
Thank you, Jeff. Let me share my screen here. All right, can each of you see that okay? All right, social determinants of health are critically important to our long-term success in managing patients, preventing chronic pain, and the opioid crisis that we're currently involved in. And even centuries ago, it was recognized how important it is to know what kind of person has a disease than to know what kind of disease a person has, as quoted by Hippocrates. So what does that mean? That we need to know who the person is who has the condition. What are their social determinants of health? They are major risk factors. For example, they can cause stress, interfere with healthy social functioning, increase pain, lack of housing, utilities, as mentioned already. Oops, excuse me. Lack of food and resources, limited transportation, childcare, lack of employment, income, lack of education, training, and opportunity. Now, in addition to that, there are other social risk factors that are often driven by those social determinants. These include abuse, trauma, work, home stress, loneliness and isolation, as we've seen with the COVID recently, conflict and negative relationships, including that with providers, and also recovery barriers such as litigation, workers' comp, etc. So we need to understand the person, and it means knowing both the risk factors, not just the physical problem, but the risk factors with those characteristics, conditions, behaviors such as poor sleep, diet, stress, repeated strain that increase the possibility of illness, injury, and pain sensitization, as well as, on the opposite side, protective factors. These are the things that will naturally reduce risk factors, include those characteristics, conditions, or behaviors such as restful sleep, exercise, healthy diets that prevent or reduces the vulnerability to developing an illness, including social factors. And so social factors drive, just like other risk factors, they drive chronic pain. And it's a cycle, it's a pain cycle that gets set up between conflict, abuse, social stressors, work, home stress, lack of a job, income, disability, poor social support, recovery barriers, and loneliness, isolation, alienation. Each of these are critically important. And so the National Academy of Medicine report on relieving pain 2011 state that our primary role for chronic pain should be guiding, coaching, and assisting patients with day-to-day self-care, including social factors. We can achieve the triple aim, better outcomes, higher patient satisfaction, and reduced cost of care if we do that. But unfortunately, risk assessment, risk reduction training, health coaching is usually neglected in routine care. It's not part of the biomedical model. There's no time to train patients, lack of reimbursement, no tools for health professionals to use. And we spend so much time on the tedious electronic records that it's really difficult to ask these questions and then have a dialogue about them with patients. So what do we do about that? I mean, it is a major barrier to long-term success with our patients. So many organizations nationally have stated that all health professionals really need to improve recognition, training, and care of pain conditions and the prevention of chronic pain, addiction, work loss, disability, and transform patients from long-term health to long-term health and well-being. So That means we do have to implement, as part of our routine care, a patient-centered transformative care model where we not just do imaging, but we test them for pain and risk assessment. A questionnaire, simply. We treat the condition as we're doing, but we also have to train the patient in self-care to reduce those patient-centered risk factors by implementing protective, healthy actions in all realms of a person's life, including social factors. Now, to do that, we have to do it as part of a team. And that would include a health coach, and I'll talk a little bit about that, health psychologists, social workers, to really support the patient in achieving their goals. We have to transform the patient and the healthcare system in this process. And so what we've done to try to facilitate that patient-centered transformative care through NIH funding, very kind funding from NIDCR, to develop a telehealth solution that does each of these components that we need to do as part of routine care: risk assessment, health coaching support for patient goals, change, and implementing self-care, lessons to simply train patients, brief micro lessons to integrate self-care into daily life, to extend your care into the patient's life, to prove long-term outcomes, to take minimal clinic time to implement, and it needs to be reimbursed and generate at least break-even records. So a patient engagement platform is very similar to an electronic medical record, only it's for patients. It implements self-care, risk assessments, has resources, reminders, dashboards, allows for appointments with health coaches, with health psychologists, and billing, and it generally is reimbursed by health insurance companies. And so the development of a program such as this, we spent a lot of many years developing the pre-development research, looking at risk factors and protective factors, and doing systematic reviews of what they are, particularly for chronic pain in general, but specifically TMD and orofacial pain. Then we implemented them within a Coursera course through the University of Minnesota, and we analyzed a risk assessment tool using these population. Then we conducted a randomized clinical trial to see, well, how does this work in routine care? Then we've implemented in routine clinical, and we've had a pragmatic trial with about 165 patients recently. So let me kind of talk a little bit about these components very briefly. Telehealth coaching, very helpful for my patients. It's a new health profession. You're probably not familiar with it, but it allows us to extend that care into the patient's life. It's all telehealth, so they work video or telephone. It helps patients set and achieve goals. They have usually multiple visits, maybe once every 2 weeks or so, all done outside the clinic. It helps implement action plans, encourage adherence, improve success and outcome, and it facilitates identifying those red flags and referral to a health psychologist or a social worker as needed. Very helpful. Risk assessments need to be done routinely to identify not only the goals and pain and past treatments, but also those risk factors and what are they doing currently to enhance their health and reduce those risk factors. It allows us to measure symptom progress and identify those red flags, as I mentioned, and a lot of very excellent validity and reliability with these questions. And then micro lessons to improve risk factors. Education is difficult to do about patients. And sometimes they get defensive. They want to know the physical problem. But in addition, they want to know what's causing their problem over time. And what can they do about it? And I was surprised that we've had about 95% engagement in this type of program to really look at all aspects of a person's life, including their social life and what their social support is, their work and home well-being, their social stressors, and how do they prevent re-injury, safe living, minimize. And you can see the risk factors that are addressed. I mean, there are so many factors that we need to really address within the context of a whole person model. And what we do that, it creates these positive social cycles and behavioral cycles to really feel, for instance, social inclusion and belonging, mutual positive relationships, how to receive and provide social support, and to achieve work and home well-being and security. And these cycles create positive feedback cycles. So that's just a very brief overview, and we've working to help others use this program if they're interested. We do have the ability to register. We have webinars about using this. We do register and train staff, and we teach the billing team how to do the billing. And we also connect with telehealth coaching through the PACT and psychologists. We have psychologists around the country who are willing to do telehealth visits. And then you begin enrolling patients. And we do get reimbursed using a code 99409, which is really preventing chronic pain and opioid misuse. And so that is something that has been very helpful for us because it does provide a positive reinforcement for clinicians to use this. So with that, I'll just end the show. Thank you very much.
And thank you, Jim. It's a pleasure to hear from you about your PACT program. I think at this point, what I'm going to do is try to draw this assembly a little bit to a close. I have some additional thoughts, and then we'll open the floor to questions and answers and give Dr. Kapos an opportunity to add her 2 cents. We've got about, well, a little over 10 minutes now. So the final concept is, how can we improve patient tolerance of those SDOH problems that they can't resolve? Consider the 12 Steps program, for instance. God grant us the serenity to accept the things we cannot change, the courage to change the things we can, and the wisdom to know the difference. Using the Texas disaster as an example again, what can Texans do to address their individual problems? When we recognize the value of our local, state, and federal government's influence on all of these SDOH factors, we can better understand the importance of these programs on an individual and personal scale. So the document that was presented earlier regarding the Vermont access to various different social programs is meant as an example of what you as individual providers may wish to do in your locale. It's simply a way of providing information to patients, even though we may not be able to alter their particular situation or circumstances. At this point, I'm going to turn the floor over to Dr. Caspo, who will present a number of questions directed at our speakers.
Was I muted?
Yes, you were.
Okay, let me repeat. I want to thank you all for being here. I like specifically to thank the panel and for their input in this webinar. This is our second best, we have 2 only webinars, and we prove that the American Academy of Orofacial Pain is the leader in this profession. I'd like to thank specifically our friend and colleague Daniele from Italy for always being with us to make great comments in these kind of webinars. Thank you, Daniele. I have a few questions. I will let the screen scroll through, and if anyone take turn about these questions would be really great. I don't want to read it. You can read it, and probably these questions for the psychologist or Flavia or Ian. Can you answer?
I think this could be a good actually connection here to this last part about what can we do about it. I'm gonna click on answer live. I think that's the way to answer a question.
You just got answer it here for everybody.
Okay. Well, so I would like to address Dr. Fillingham's question. It's just actually an honor to get a question from you, who's such a leader in the field, and I'm excited to now get the chance to have a seat at the table. So I would, so the question is about, we as clinicians have ways to address biological and psychological targets, and we know that the social determinants, they are embodied, or they affect health through these pathways. So that's one of the reasons that we've focused on that. And that's understandable and justifiable, but I think that how can we target the social determinants more directly, right? I think that the whole field of social determinants of health is grappling a little bit with this question. We've been really influenced by a way of thinking, so an epistemological stance that is that puts scientists in kind of a neutral position. So this the biomedical model, for example, is aligned with this positivistic stance, where we're supposed to try to observe and describe reality as it is. So this is not really conducive to acting on the structural factors, and we need to overcome that. So adopting a more critical perspective is definitely a way to go, but in health, we're not really used to this approach. So I think one way that we can make a difference and move this agenda forward is to connect across disciplines with which we're not really used to at this point. So perhaps more in the social sciences, and thinking about public policy. And then also at the clinician level, I think we can also think of ways to get engaged, not through the classic, one-on-one intervention with the patient, but using for example, our influence as trusted messengers. We can try to start changing this culture around health equity by having these conversations with the people we know, for example, by writing op-eds and lobbying for a response from government and other organizations to prioritize health equity in by means of advocacy or legislation. And I think that we also have a role in that beyond the walls of the clinic. But also, last comment, there are some interventions that are clinical interventions for social factors, for example, at the interpersonal level, interventions with families, and there's particular evidence there, for example, between parents and children, and trying to break that link between intergenerational transmission of pain. So we don't have all the answers, but I think we'll get there if we connect across disciplines, because social determinants have such a broad impact, and we don't need to be siloed in the pain world. And I think we'll get further together for a collective problem, having some collective solutions.
Any other comments from Ian or Ron?
Yeah, if I can just jump in here very quick and add on to what Dr. Kapos was saying, by talking about psychological interventions, one of the comments that was posed in the chat was, has changes in insurance coverage during the pandemic made access to care for mental health services better? And yes, it has. It used to be the case that telehealth services had very strict insurance regulations for billing, and a lot of those regulations have been relaxed. So billing for mental health interventions, telehealth mental health interventions, is now much less, there's much less requirements for that. So I want to answer that question. I also want to answer another question, or make another comment about the resource tool that I mentioned. Someone brought up, Dr. DeLeo brought up that a lot of the times those people who need that, those resources might not have access to internet or a computer where they can have like a link to the resources. So actually having a paper and pens, a paper brochure or a hard copy of what those resources are would be really helpful for having greater access to the resources with the people who need them. Thank you.
And I'm going to just add to what was said about the outreach possibilities. There's some specialties that that other fields, not orofacial pain, but other fields of pain, sometimes access a little bit more effectively. Sometimes we get aghast at thinking about the fact we could actually get on the phone and talk to attorneys who are advocates, as well as disability organizations and so on and so forth. And those are actually often resources that address a lot of the social determinants, and they're sometimes available, but again, we're not always comfortable at accessing those, but they are out there as resources.
Okay, takes us to the second question about smoking, about other issues in poor countries. I think I'm not sure really who is willing to answer this question. Probably Jimmy Fricton will have some kind of answer for us.
Well, let me kind of address this from our perspective. I mean, this is a complex societal problem. I mean, smoking and many of these behavioral risk factors and social risk factors. And I think that when you go to a healthcare provider, if they only focus on the physical problem that they have, it's neglecting the vast majority of change that can occur. And hunger is a huge social issue. And first we have to, if someone's coming to us for care, we have to identify these factors. Whatever, we have a paper and pencil questionnaire or online or whatever, I think that we need to address those. And it's in the whole health equity issue and the people who are marginalized and low income, we have to have access to care for these patients. And that means that we have to be in network with medical assistance, Medicare, and all the insurance companies. And that's one of the difficult things in our field of orofacial pain, is how do we become in network with health plans to be able to do that? So both improving access to care will be very helpful, but also really we have to identify these factors at our initial visits and work with the patients on that. That's where we have used health coaching, health psychologists, social workers to really work as a team in that regard. But I'm happy to hear other people's comments also.
If I can add my 2 cents, I'd like to emphasize what Jim just said, because the fact of the matter is, when you get right down to it, lots of patients do not have access to any kind of care, let alone orofacial pain care. So under the circumstances, there are conditions where we cannot possibly expect to solve a particular problem that patient might be experiencing. It's important for us, I think, to give this serious consideration, because it does influence our patients' lives tremendously. But we here in the United States in a privileged environment do not have the opportunity to provide answers for the, shall we say, indigent of India who are not capable of accessing any kind of reasonable care. Cigarette smoking is probably the most inexpensive way of solving a lot of problems, even though it creates problems of its own. Just my 2 cents.
Okay, so I think the question before that asked, if we use the screening tool AAOP, what is the recommended action with positive results? Ian.
So I would say that this also depends on the context and what the resources available to you are. But at the very least, I would encourage people who use a screening tool to have a plan for positive results, and that should include directing people to some of the resources, like I mentioned, and having a physical copy of those resources on hand. A lot of times if you're in a university setting, it might be a good thing to reach out to social work or other departments in the university who can help you compile this list of resources or generate those resources. And I think that the specific action plan for each of the positive screenings is going to depend a lot on what's available in your specific context, but that would be my short answer. First, to have a plan, and second, to direct people to resources that might help address that specific need.
Any other answers from the panelists? I guess that's it. I thank you all for your time and for being here and for the orofacial pain field. Jeff, Dr. Crandall, do you have any last comment before we adjourn?
Sure. I'd just like to thank everybody for their participation today. I hope that this conference has been somewhat helpful. I think that the issue of social determinants of health is actually a very up-and-coming field in orofacial pain, and it's a topic that needs to be considered and discussed, even though we don't have solutions for everything at this time. But thank you all for your participation. I do appreciate the panel's efforts. Thank you.
Thank you.
Thank you.
Thank you.
Thanks, everyone.
Thank you, Jeff.
Thank you.